But Dr. Sasser is an MD, and he has, after MD, FACS, which is Fellow of the American College of Surgeons. Dr. Sasser is a graduate of the Medical University of South Carolina and is board certified in general surgery from the American Board of Surgery. He completed his internship, New York Medical College, and he did his residency at Greenville Memorial Medical Center. Since Dr. Sasser came to Horry County in 1992, he has striven for excellence in general surgery for our community, and I can confirm that. Dr. Sasser is an active member of the Conway Medical Center and Waccamaw Community Hospital, and I believe that, and I'm sure Dr. Sasser is going to convey the serious concerns that he has from a medical professional perspective on Obamacare. That's why it's so important that we get rid of this character in November and repeal it. So, if you would, give a hand to Dr. Sasser.
I'd like to thank you for having me. I'm going to talk about what I know the best, which is my work. I don't know Obamacare in great detail, but I know what I do every day. And I think a lot of you may know the bills. I know the trenches and the nuts and bolts and how this affects me now and what's going to happen and what's coming. So what I'd like to do is just tell you a little bit about me, about my practice. And I'd like to keep it open, so if you have things you'd like to ask me as we go along, please raise your hand. I'll be happy to address that. I was actually born in South Carolina. I lived here in Conway until I was 10 years old and moved around all over the country and decided to come back here because I just love this area. And so I set up practice in Conway about 1992 or so. And I can see a lot of familiar faces, friends, patients. And so I was happy to come and kind of share my thoughts about the Obamacare with you guys. I started off in practice here, came back home, and when I started off, things were so different back then. And I went to college, studied hard, got a degree. That's a lot of work to be a doctor. The kind of sad thing I've seen lately is some polls that show about 90% of doctors today don't encourage their family to go into being a doctor anymore. And I think that's sad in a way because I came from a medical family. There's a tradition, I think, in this community of people who grew up in the medical community. And you see many doctors today who say, if I had it to do over again, I'm not sure if I would do it, or what's my 5-year plan? How am I going to get out of this? Or if my kids had the opportunity, could I really encourage them to be a doctor today? And I think these are really sad sentiments for a traditionally rather respected field, and to see the degradation of it, and particularly what's coming, I think is a sad statement. There's a couple items I wanted to talk to, and one of them is to address the Obamacare bill and what it's done to affect my practice so far and what it's going to do to affect the practice in the future. Basically, what they've done with the Obamacare bill is to look at Medicare, which Medicare, as you know, is what seniors get most of their medical care from. And they've basically decided we're going to go into Medicare and rob Medicare and give it to Medicaid, which is about like robbing Greece and giving it to Spain. It makes no sense. But that's been their desire, is to figure out a way that we can take money away from seniors and basically give it to the Medicaid population. And so what they've come up with in this plan, which will really unfold over the next few years, is a way of limiting access, limiting funds that are paid to the Medicare recipients, taking that money and shifting it in other directions. And I would have to say this for my practice. I do vascular surgery. I work at the nursing home a lot. And so about 70% of my patients are over 65. And so my practice is far and away people who are on Medicare and people who have been retirees. That's who I take care of. And so this is going to affect me and my patients substantially. It concerns me when I look at the projections. I don't know how I could stay in business and run my business the way I've run it up to this point over the next 5 years. I just don't see how it's going to be feasible if they implement everything that they're talking about. And so I'd like to get into some of those details so that as you go out in the community, you can kind of know what are the things that are going to come, how will it affect me and you, and what could we do to maybe change that. They're talking about some of the changes that are coming as soon as January of next year, which will be basically paying the doctors in a different way. In the past, you were paid based on the number of people that you saw. Now what they're talking about is paying people based on performance, which in theory is not a bad idea, but the performance measures really are not so much quality of care measures, they're more how good are you at reporting back to the government your information. And so what we've had to do this year is we had to spend about $240,000 in our group on an electronic medical record system, which is a very big problem, I think, with our office today. A year ago, we averaged about a 15-minute wait. Now, if you're the last one in the office, you've been there about an hour and a half. And so in the last year, it's limited my practice in the number of people that I can see in a day has gone down about 20%. Plus the people who are seeing me are mad at the end of the day because they've had to wait a long time. And so I think one of the strategies, I think, in limiting access is to make it cumbersome for the patients. You come to my office, we have to fill out a very long electronic form. It takes a long time to fill that out. So when you come to my office for the first time, you may wait an hour and a half to see me. Most people are pretty good about that. It probably bothers me more than it bothers most people, but that's burdensome on most people to come and sit that long and wait. The other thing they do is this: they take this information that we put into the computer and we enter it in such a way that it can be mined. It can be taken out. It can be used. They say they won't use it in various ways, but you know what's going to happen when this is all categorized. I take all of your information, every medicine you've ever been on, every surgery you've ever had, every diagnosis you've ever had, and I put it in the computer. And then they can go in there and pull any bit of information about you that they want. And this is why they want us to put this in electronic medical record. You can't go into a handwritten or dictated note and pull all that out very easily. But if it's categorized electronically, it's more conducive to data mining. And so this is sort of the starting point. How can we take your information and put it in a way that we can get it out? And then that's what they use for us, for the doctors, to see how good a job we're doing. They want me to report all of your information, and if I don't do that appropriately, then they cut me by a certain percentage. And so my reimbursement is basically not based on the fact that you had a good outcome from your surgery. It's based on whether I meet their various criteria for establishing the information that they want to get back from me. The way they have paid us in the past is interesting. They have a formula to pay the doctors which is based on a sustainable growth, which basically means this. They look at the growth of Medicare, they look at the growth of our economy, and they say, we will only pay the doctors at a certain percentage based on the economic growth of the country. Well, every year for the last 10 years, based on this formula, we have had a cut. And it's been, on average, about a 2% pay cut every year for the last 10 years. So in 2012, I make 20% less than I made 10 years ago. Now, you know, you handle that. I can live with that. I don't like it. But, you know, you learn how to tighten the belt. You learn how to kind of squeeze a nickel here and there. The problem is they've done this to us for 10 years. Going forward this year, if the cuts are allowed to expire in the end of the year, which they are planned, we would get, all doctors across the board, we get a 29% pay cut. Now this is for Medicare patients. Now this has happened yearly now for about 6 years. And so for my practice, every year at the end of the year, unless Congress acts, there's this 29% pay cut. Now I don't know what business you've been in, but what business could really take a 29% cut? So we have that looking forward every year, so it makes it hard for us to plan. It makes it hard to really go out and hire new people or buy new equipment when every year you think, you know, unless something changes, they're going to cut us 29%. How can you go out and do much? You can't. You really are always living in this fear, and so what happens at the end of the year is they say, well, you know, we're really not going to take the 29%. We're only going to cut you 2%. And so, you know, be glad that's all we're going to do. And so that has happened, and that will continue to happen. However, going forward, in the Obamacare plan, they've got a different system. They have a entity, which if you're not familiar with, let me ask you this. How many people are familiar with the IPAB? You know what that means? Okay. IPAB is, it's a board that is in the Obamacare plan, and basically their job is to find ways to cut spending in the Medicare payments. It's basically this. It's a 15-member board that will be appointed by the president, and they have the authority to determine what Medicare will pay and what they won't pay. And they have the ability to decide, particularly it's related to doctors and hospitals. Their recommendations will be law unless voted down in two separate votes. First vote is that if Congress wants to vote this down, Congress could vote it down. But then they have to have a second vote, which entails a new program that would have equal amount of cuts to the first program, which is really impossible. And so basically this 15-member board, which is appointed by the president, will have the ability to determine what Medicare payments will be over the next 10 years. These are people who are appointed by the president, who are not ratified nor voted upon by citizens, and who will be on the board until 2017, at which time they'll have new appointees. If you're not familiar with this board, I would very much encourage you to find out more about it. It's called the, let me think what IPAB stands for. Independent Payment Advisory Board is what it's called. This is in the Obamacare law. It's something that Paul Ryan and a lot of the Tea Party people around the country are very much focused on. As far as in the upcoming election, it's going to be a big focus on particularly from the Tea Party and from doctors. What I've learned is this: if you talk to patients are deathly afraid of a government takeover of healthcare. Patients are deathly afraid of the government coming in and deteriorating what has been the highest quality healthcare system in the world. And people are afraid that they're going to be told by the government, not by their doctors, what care they can have, how they can have it, and what's available to them. And so the transition that's occurring is people like me and you who sit down and decide your care have to go through now these boards who will tell us if we can do that or not. And so that's going to be, under the Obama healthcare plan, it's going to be a system where if I don't, as a physician, do what they ask me to do, then they will say, well, you haven't met our criteria, we're going to cut you by a certain percentage. And so what's happened is this: many physicians, particularly my age, are looking at early retirement or getting out of it or finding something else to do, which is kind of sad too. I mean, I'm 52 years old. Most doctors my age would practice for another 13 years or so and retire maybe. I know a lot of guys my age that are not going to do that, and so it's kind of interesting to me when I go to the meetings now. There's really two groups of surgeons that I see. There's the guys who are my age and older, who look like your traditional doctors that you see, and then there's all the guys younger than me who are from various countries around the world and aren't really American trained physicians. And so I've found that as this physician shortage is occurring already, there's this shift from American trained physicians to people who are trained all over the globe who really don't have the standards in their training that the American physicians have. And I don't know how many of you here have doctors that weren't trained in the United States that are your physicians now. It seems to be a necessary problem because most of the American doctors are just sort of getting frustrated with it. And Jerry asked me today, she's like, what are you going to do 5 years from now if this all goes through? I said, well, got my captain's license, I'm going to be a fishing guide, most likely. and that's quite likely. I know. So you have to have a contingency plan. Yeah.
Well, some of us who are in the military know how you believe me that if you use the VA hospital, that's the government's health care. And I have seen, and I have had, not American doctors. They're foreign doctors. Some have had good ones, some I don't know about. The one I have here in Myrtle Beach, he seems okay. He likes to talk to me. He has an accent, I don't know where from. I'm not sure exactly, but well, he did find out something that I wasn't found when I used to live in. I came from Rhode Island when I moved down here. But up there, same thing up in the eastern states. I had a foreign doctor, and they weren't thorough with finding what was wrong with me or what something I had. And this doctor here did find that I needed to have a kidney removed. Luckily, he found cancer and got rid of it in time. And supposedly my cancer is removed from their MRIs. But there is more of these foreign doctors in the VA hospital.
And I think that's a good point too. Is I'm glad you brought it up about the VA hospital. I actually worked at the VA hospital for many years. I was in the Army for 8 years. I think it's atrocious what the VA system has become now. I don't know how many of you, how many have been to the VA system? How many would prefer the VA system over private care? Zero. And so I have many patients who come to me who are VA patients who say, I've been going to the VA for months with this problem. Can you take care of it? And having retired military, I always am going to look out for these guys and rarely get paid, frequently get paid nothing. But a lot of the VA people go to the clinics and they say, I've been going there, nothing's happening. And I think it's a really sad hospital system, which at one time was better, but it is basically what Obamacare would transform our entire health system into, like a VA system, if they could get it to that point. I have a lot of friends who are foreign medical grads. I think there's some excellent ones, but as I said, it is training.
Can you address what will happen with your private insurance once the Obamacare kicks in? You have the option to.
Yeah, that's a good question as well. The question was this: what will happen to private insurance?
As far as if you're on Medicare, like that.
What will happen is this: it's going to go way up. There also, if you have a Cadillac, quote Cadillac plan, you will pay a penalty for having that. You'll pay a surcharge on having. Say you want to get a better insurance, you can afford that. You'll have to pay a luxury tax on the fact that you bought better insurance. The price of private insurance is going to really get higher once this Obamacare kicks in, because basically premiums have already gone up just in anticipation of what's going to happen with the Obamacare thing. I'm definitely not an insurance expert, but I can tell you this. The number of people that I have that have private insurance has gone down because many people can't afford it. And so it's become less affordable.
What can we do then, as a group, to help change this whole concept and get the people out there to know?
Yeah, that's a good question. What can we do? What can we do as a group? I mean, I think we know a few of the answers. I really don't know. I mean, a lot of the Obamacare. Let's say this. Talk you off the ledge a little bit. There are some things in there that aren't terrible. There are some things in Obamacare that make sense, such as if you have a pre-existing condition, you shouldn't be penalized for that if you want to go get that. If you have a kid that's 26 years old, they can stay on your plan until they're 26. My kids, when they get to be that age, they need help. You can't be you can't be penalized if you have if you move across state lines is another thing. So there's some good things in it. I think the biggest thing in it though is this: when you look at the gist of what's going to happen, it's basically going to take the money from retirees, take away retirees' benefits, and take that money and give it to poor people. Is what it's doing. That's the gist of the whole program.
Dr. Sasser?
Yes, sir.
If we could, let the doctor finish his discussion, and then we can start doing Q&A.
I really don't. I'm really more of a QA speaker, if that's all right. I really don't mind that. But I'm sorry.
No, I was just going to say, I'm not sure, but all day long they've been talking about the $762 billion, so that must be the Medicare dollars that's going to go into Medicaid. Because we got the Dems out around the country saying that, no, it's the Republicans that are going to do that, but I think it's what you're saying then, so that's got to actually be the Obamacare taking that amount of money, because I must have heard it at least 25 times in different discussions all day long and all, so that's got to be the amount of money that's coming out to go to Medicaid. I think, I'm not positive.
I'm not positive about it.
Keep talking about that.
I don't know if I can answer your question on that.
But the other thing, could you just
I go to
explain?
Dr. Covington's primary care doctor. And he was saying, I've always, and I work for a medical clinic, I also work for the state agency, but I always assumed that electronic medical records were cutting edge and, just top of the line. He said even before it came out that there's research to the contrary.
That's exactly right. I'm glad you brought that up. That's a very great point.
I was going to ask you to.
I would love to talk about electronic health records. I will say this going into it. I'm pretty much a computer nerd, which is strange for a guy my age, but I've written my own programs. I know computers very well. The problem with it, let me just give you this as an example. You come to my office and you're a new patient. And I have to take all of your information and key it into a computer, which takes time to enter each little bullet individually. Now the advantage of that is if you were somebody that came to me as my long-term patient, I would have you there all the time. But as a surgeon, I'm going to see you, take care of you, and then hopefully never see you again if everything goes well. And so with the electronic health record, first thing is, it takes a lot of time. The second thing is, you would think that when they made this, they would make it so that one system would speak to the other. Not in the least. So if you come to my office today, and I put you in my electronic system, and then you go to the hospital, I have to take that out, print it on paper, fax it. So it faxes to the hospital, and then it gets scanned. Actually, it gets put, I'll take it back, it doesn't get scanned. That paper that I fax gets put on your chart. And so I can't possibly see on your record at the hospital electronic records from my office. It's on paper. And so what happens is there's no conveyance of information from your family doctor to me. And the thing that struck me was if they wanted this to flow, they would have made it where each system speaks. That's not their intention. Their intention was not to make my job easier. The intention was for me, when you come there, to be able to data mine all of your information, and it doesn't really matter to them if it's flows from one doctor to the other. But to answer your other question, which I want to speak to, is this: there is no evidence whatsoever that taking a person's information and putting it in the computer has any effect beneficiary to your health care. In fact, there's actually studies to the contrary that show the electronic health system, now it's an early system, no question, but to date, it's actually more liability. I will have to say this: if you look at my records now, they're not nearly as accurate, complete as what they were a year ago. And there's frequently misinformation. There's stuff that's entered incorrectly. It's jumbled up. You can't really read it, and it's just a very awkward, primitive system. Yes.
Yeah, I just also comment that that's the system is implemented in the VA hospitals. I'm already in the system with the VA, and it's all computerized. Everything that was done about me prior to any surgeries, everything, my prescriptions. So I can also order prescriptions over the website that they developed for the VA hospital that way too. Some of that is good stuff, and I've heard there are some mistakes, I know, because I've had some mistakes on my part where they didn't know that I had a prior surgery and it was in there, but they didn't find it until they had to go back to another VA hospital where I was to find it. So there are, to me, a lot of information can be put in by a computer person who's putting it in.
It's a program that's technically very difficult to work with. It's not at all user-friendly. Most of the information, when you come into the offices now, are keyed in by either nurses or nurses' aides or even people who aren't nurses. Sometimes are putting some of the information in. And so it's not entered, I don't think, as well as before when I was the one entering all the information. Now I'm not.
You were talking about before when Obamacare is implemented, there'll be a time frame that you've got to sort of get permission. Is there going to be a time frame that you, for instance, someone has cancer and you need to operate right now? Or do they say, oh, I'm sorry, you just got to wait that 5 or 6 months?
The time frame is in this way, and I can tell you, I can answer that in a different. I had a very good friend of mine, my best friend in school, who went to England, and he did a fellowship in thoracic surgery in England. And in England, they have a socialized system. And so what happened there, the doctors who were the thoracic surgeons, the misters is what they call them, they were the highest doctors in the country. They make about $80,000 a year, which is
chump change for a doctor.
For a doctor, yeah. That's what the top doctors at the university make about $80,000 a year. And what they do is they go to work about 9 or 9:30. They work for about 3 hours. They take a 2-hour lunch break. They have a pint of beer. They come back. True, that's true. And then they work till about 4 o'clock, and then they leave. Because there's no real incentive in the socialized system to see more people. You're salaried, you're not, yeah. And so in England, what happens is, unlike me, who works for you, I work 12-hour days. I work a lot. I've got you coming to me. I'm a service provider. You need me. You want to see me today. You don't want to have to wait. And so under this system, it's imperative that I make you happy because you know, I work by word of mouth, reputation. And so what happens in England is this. If you come in and you have lung cancer, they find it, they diagnose it, the average wait for surgery is 3 months in England. Now I can tell you this, if you look at the United States, 5-year survival for lung cancer, and this is all published in the United States, is twice what 5 years, what it is in England. What I'm saying is this, if you have lung cancer in the United States, they call this 5-year survival, meaning how many people who are diagnosed with lung cancer are alive at 5 years, okay? In the United States, our rate of lung cancer survival at 5 years is double what it is in England. And you can look at any cancer diagnosis, prostate cancer, breast cancer, colon cancer. We, in the United States, are way higher in our 5-year survival rates than England. It makes sense, doesn't it? I mean, you don't have to be a doctor to know if I'm got to wait 3 months to have my surgery, what's happening? It's growing, it's spreading, it's...
Is it accurate then to say that in essence we have no insurance? Because we're not given the opportunity to go to an insurance company or have anybody, whether they're in the parameters, to talk to about the kind of insurance we want. We really don't have any insurance then. The government is determining what can happen.
Well, the government is, particularly for people in Medicare. Now, if you've got Blue Cross and things like that, but if you're in Medicare, you're really government.
Mercy.
Yeah, you're really at the mercy of what the government allows.
I listened to a radiologist.
Speak up.
I listened to a radiologist, doctor, talking about, and she primarily was dealing with breast cancer. And she said that in Obamacare, the way they're going to have it, I couldn't hardly believe it, was that the women were going to start getting their initial exam at 50, and at 74 they're cut off.
Right. There's a couple of things that changed, and her question for those of you who couldn't hear it was this. Under Obamacare, what's going to happen for routine screening mammograms? Actually, they are moving that back. The age will be set back. Same thing with men in Obamacare. Traditionally, PSA levels, which have been a big deal, those are gone. They don't do PSA levels anymore. Those are just completely... And so if you go to your doctor under Obamacare and you want a PSA level, you have to pay for that out of your pocket. That's not covered anymore, which was really a very much routine, I mean, I think for men, most men, if you're going to live to be 80, you're going to get prostate cancer. And now they've said, well, we're just not going to pay for what was probably the best screening tool of any cancer screening tool in the country was the PSA level. That's out. That's not even going to be paid for. Now they will pay, like I said, I'm talking off the ledge a little bit, they will pay for if you are a poor person and you don't have any money or any insurance, you can go to every doctor and you can get a doctor's visit and you don't have to pay any copay. And so what's going to happen is everybody can go to the doctor with no copay now, and it's going to be this huge floodgate of people going to the doctor not paying any. I kind of like the copay in this way. It's $20. Now, I'm not going to go every day if I got to pay $20 out of my pocket. I'm going to go, if I got zero copay, you're going to go every day. You're going to go for everything. And so, their thought was, well, we'll just make it where they do a copay for Medicaid patients. Look how good we're going to do with cutting back, but they're not going to cover a lot of the screening exams. They can't. Yes.
Correct me if I'm wrong, if I heard you correctly, did you say that Medicare payments, reimbursements back to doctors have been being reduced 2% from that?
Yeah, let me say that. That's amazing, isn't it?
And that started before Obamacare.
Yeah. For the last 10 years, every year, they have cut, on average, 2%. Now, I'm looking at next year, 3%. I'm just talking about across the board what Medicare pays me. It's going to be cut 3% next year. That has happened to me every year for the last 10 years. I've had a 2 or 3% cut in my payment at the same time that my business costs have been going up, my insurance costs, my practice costs have been going up. Yet over the last 10 years, I've had probably about 20%, and that's not even adjusted for inflation. That's just a 20% cut.
Was that a result of the government trying to cut back?
Exactly. Yeah. Yeah.
Okay, that's surprising. Okay.
Since Obamacare came out, I've been trying to find the entire manual. I'll tell you what, I really had some difficulties with it. So what I started to do is ask some of the doctors that I visited. Some of those doctors did not receive that manual. Did you have it?
No, I haven't. In fact, I will say this. You guys are way more informed about Obamacare than the doctors. But I'll say this, I'm one. We're terrible. We are terrible because we're working all the time. I go to work at 7 o'clock in the morning and I stay there till midnight. I don't have time to do what you do, which is to be knowledgeable. And so all of my friends know nothing. They know nothing. None of the doctors get involved politically. None of them know any of the things that are coming down the pipe. We don't have a manual sent to us. Basically, it's two things about doctors. They don't want to think about that. And it's like herding cats. It's like doctors are fiercely independent, have no respect for authority, and always welcome to the Tea Party meetings.
I know when I tried to get online. Now, if you go back and you look at when the Supreme Court, they based their findings on, what was it, 27 or 2,800 pages. You go online from the government, you only get 2,300. What the hell's the rest of the pages? It's not there.
Not available. I'm sorry.
That's what some of the congressmen are saying, where's the other
Yeah.
pages?
Dr. Sasser, I wanted to say, you said earlier, 100% about the American doctors that come in. This particularly happened to myself and my wife already. About a year or so ago, I had to make a decision. I had a really good American trained doctor, and I love him very much. He saved my life, as a matter of fact. But he came to me one day, and we had a big meeting about MDDIP. Have you ever heard that?
Yes.
And now what he said to me, we went to the Hyatt, and we listened to this whole thing. It was atrocious.
It is.
I can't do it, but what it amounted to was that each one of these doctors who had 2,300 patients now are limited to 600 patients now. But you have to pay $1,500 per person.
That's amazing, isn't it?
Every year. And this, I believe, has something to do with it.
You know what it is?
The handwriting on
Those are the good guys. The really good, and these are all primary care doctors that you're talking about. If you're a really good primary care doctor, you can say, listen, I'm only going to take you, it's kind of like a Sam's Club membership. You pay me $50 a year, and you can come buy wine at wholesale. So it's the same thing. You pay them $1,500 a year. And the problem is, how many people can afford that?
Well, that's it.
Not very many. But
I had to change doctors.
Well, most people do, and there's a few that don't, but most people do.
And doing so, I don't have an American trained doctor now.
Right.
So I mean, and I think Obamacare had a lot to do with these two doctors making this particular.
Well, it was, I think, and the other thing is this, I bet you when you go to the hospital, your doctor won't go there either.
Right, exactly.
That's the new trend, is like for me, you come to my office, you go to the hospital, I see you, my office, the hospital, the whole way. You go to your primary care doctor, and then you go to the hospital, you have a hospital doctor, a different one every time you go. And then they send, and an interesting thing is, a lot of times they will write medications and you get back to your doctor, and he'll say, well, I don't agree with that. And they won't go along with what the hospital does. And I just think it's bad continuity of care.
I'm a physician, also semi-retired family practice, but I think people don't realize that the cost control is going to be restriction of access. And there's a well-publicized Canadian patient who had headaches, and went to his doctor, got a regular x-ray of the head, and didn't see anything. His neighbor said, well, you might have a brain tumor, why don't you ask him for an MRI? Went back to his doctor and he said, 5 months,
Right.
I can get you an MRI.
There are more MRI machines at the Mayo Clinic than there are in Canada.
So he went to Buffalo and got his MRI, and he had a benign brain tumor. Brought the MRI back to his doctor in Canada, said, now I want to see a neurosurgeon. And that was going to be almost a year.
Exactly.
So he mortgaged his house, went back to Buffalo, had his surgery. Now he has a $45,000 bill, which he took back to the Canadian Medical Center and they laughed at him.
Right.
And the other thing is you wait 18 months to get a gallbladder in Canada.
Right. I mean, I think we all know, if you've had any friends or relatives that are from Canada, the Canadian system is much worse, I think, than the British system, because the way they limit it is they just don't have that many machines. They have about 8 MRI machines available in Canada. And so most Canadians, if you want to have an MRI, you come to the United States and you pay for it out of your pocket. Otherwise, if you want to wait for one of the machines in Canada, you're going to have a long wait. Like I said, there are more MRIs at the Rochester Mayo Clinic than there are in the entire country of Canada.
I was reading something or saw it somewhere. Apparently, Canada is trying now to get back to a system like we have.
They are.
But it's very bureaucratic and very slow in happening, but slowly in certain areas that they're going back to the system just like we have.
Well, what you have is in our country is going to be a 2-tiered system where the people who are used to getting good quality medical care, such as yourselves, are going to be limited. The people who have had no insurance, who have the same vote that you do, but they don't have any insurance, they're happy.
We might have to go to Canada.
Yes.
Is there any truth that care would be denied based on age? I hear this.
You know, I've read a lot about that, and it's not written into anywhere in the Obamacare. Basically what she's saying is this. In England, they have a system where they look at your age and your contribution to society, and they factor your age. Even your chances of survival. So for example, if I had a patient come in who had a life-threatening problem that I could do a vascular procedure, but she's 94, somebody, IPAD, would say 94-year-old lady is not going to have. You know, there are 94-year-old ladies who are very active and very full of life and energetic and happy. And that's not like some other 94-year-old ladies. And so at least I will say this, to my knowledge, no, that's not presently written into the Obamacare system, but it just follows that would be, you know, the next progression.
I've had a triple bypass and I've had a stent. I've got heart problems, diabetic problems, and everything. And I'm 65, going on 66. Now Obamacare comes in, and because I have all of these conditions and say I need another bypass, they're going to say no because
Correct.
the first one didn't work?
Correct. Well, you know, these things that you're telling me right this moment, these are not their first attack. They're not going to come out and voice that. That's going to be the next. So right now, no, that's not written in there. But let me ask you this. What's the purpose of putting a board of 15 people to make the decision on how the money is going to get cut, if not that? What is the purpose? To have control. Yeah. To have a panel Yeah, and the panel the ITAB panel is amazing. It's 15 people. Whatever they vote on is law. Okay, it is law. Unless it is voted down twice by the House, once voted down, second, a new law that can't be cutting any less than that one, then has to be ratified by a 3/5 vote of the Senate. That's what it takes to override what this panel would put into law. Do you follow what I just said? Is that
Illness, in other words, if they have a specific criteria for what you do for cancer, that's a law, and if they have another criteria for heart disease, that's a law, or everything?
basically, the law says that the 15-member panel appointed by the president can decide how the money will be spent, and if they can't come to a decision about it, then the Secretary of Health and Human Services gets to make the law.
And the power is there.
The power, the Secretary of Health and Human Services.
They'll say no to every one of us in this room.
Last question,
Yes.
last question.
Last question.
Can you tell me what is the doctor fix?
Yes, the doctor fix is this. Several years ago, they put into place a law that said we're going to figure out a way to cut expenditure in Medicare. And so we will only pay the doctors a certain fixed amount, and it's related to the economy. And so if the economy doesn't grow at 3%, but healthcare expenses grow at 10%, we're only going to pay the doctors 3%. And so based on the formula, if they implemented the law, it would be that I would get a 29% pay cut in November. Now what has happened with this law is they haven't implemented it. So every year it's a can that's kicked down the street. And so what happens is they say, well, you know, if we went by the Dr. Fix law, all doctors would be cut 29%. Well, the problem with that is, I'm a fishing guide now. I'm not going to do that. And so they can't really cut. Let me explain it to you this way, then I'll stop. Think about a doctor as you would think about a contractor, okay? If you were a business person and you built houses, somebody with insurance, I get my fee, what it costs me to cover my overhead, plus 12%. That's what I take home for my pay. If you're a Medicaid patient, I get my fee, what it would take, I don't get 12%, I get 10% less than what it costs me to take care of you. So I'm actually losing money on them. For Medicare patients, it's about a 2% loss. So private insurance basically is how you make your money. You lose this much on Medicare, and you lose this much on Medicaid. You follow what I'm saying? And so what they're talking about doing is taking the 2% that the doctors are getting paid and lowering that even more. And so basically, what doctors are going to, if it goes the way it's talking about in 2017, you would get paid less for taking care of a Medicare patient than you would for a Medicaid patient. Yeah. All right, really last question.
Under the premise that your preaching is required, unless somebody opens the door by mistake, what is your constituents in the medical field, other doctors, nurses, what can they do, or how much can they do to educate people who don't seem to know for some reason? It's inconceivable to me that we're going to vote in a system to allow something like this marches on Medicare, Obamacare, abomination, whatever you want to call it, would take place in this country.
Yeah, I don't know the answer. You know, if I knew the answer to that question, I would probably not be in this room right now, I'd be somewhere else. But the question was this: what can doctors, nurses, health professionals do? And the problem is that we're very limited in this way. I have a friend who, he just decided he had it, and he was going to opt out. And so he decided to opt out of Medicare and Medicaid. After about a year, he was broke. And he went broke because, let me ask you this, how many in this room are going to afford to come and pay me $14,000 to do a life-saving bypass surgery on you? Who can afford that? Not very many people can afford to pay the price for a hospital visit, surgery, out of your pocket. And so you're stuck with the fact that your health insurance is government-based. I'm stuck with the fact if I'm going to take care of you, I have to accept it. So either I opt out or, yeah. Now we do have, we do have to find a way to control it. I mean, it is out of control. Everybody would agree it's a problem. Everybody would agree that we got to fix it. But I don't think, as I said, stealing from Greece to pay Spain is the fix, which is what they're talking about, basically stealing from you and giving it to Medicaid recipients, how they're going to pay for it.
I told you.
Listen, thank you, Doctor. The doctor, I think, had enough time standing there for about 50 minutes. But, one of the things I was thinking of, too, is I've heard the figure about adding 30 million people, to the rolls. Where are the doctors?
Only fishing.
Yeah.
Fishing.
Fishing, yes. But that's another number just to keep in mind. You want to see the lines that you're going to have to wait in to have a doctor see you if